Hello, everyone, and welcome to our second of the Ask a Clinician webinars. I know you're all expecting to have Nick Welln here as chairing, but unfortunately he's got a serious bout of tonsillitis, and so he's asked me to step in instead, which of course I don't mind. Thank you everyone who's come along to join me and Sobath Premaratne, talking about his point of view, his understanding, his workflows and workloads around vascular surgery, but also his interaction with digital worlds, your EPRs, your data analysis centers, and so on. Sobath's a very interesting character, and I'm very happy to have him here talking to us. He is a current vascular and endovascular surgeon at Bart's Health NHS Trust in London, and a respected member of the Health and Care Group of the British Computer Society. He's also classified himself as an X-requirement analyst and also a software developer, but I think he's very much keeping up these skills at the moment, building some very interesting apps, one that he'll be talking about at the Let's Talk Digital Conference later this year on the 24th of October. Sobath, thank you for coming along to talk to us today. I'm just going to take you off of mute, and the floor is yours.
Thank you very much, Mark, for inviting me. I hope you can hear me very well.
Yes, indeed. Yeah.
Yeah. Okay. Thanks. So so it's quite interesting and thanks for the opportunity to talk about my work as well as my surgical work as well as digital health work. So my ICT work started even before like my medical career. So I started with the Australian Computer Society exams, and first I delved into like programming techniques. I've been writing code like since since O level, even before O levels days, like using Pascal, GW Basic. I mean, it shows how old I am. But then I got quite serious with C++ and C sharp. And then I thought I need to learn the principles behind all this. So that's when I started doing these exams. And after doing the Australian exams, I got the Australian Computer Society membership. And then, of course, I won some awards from that as well. Then I moved on to British Computer Society exams and then did some of those and then won an award from there as well. And then, of course, then I went in to do my medical training. But then after I finished my medical training, I did some more IT work, like because I was quite keen on machine learning. I just did the machine learning specialization from Stanford University, Andrew Ng's course, which was really interesting. So coming back to what I do day to day as a vascular surgeon, but most of my work involves vascular surgery, which I don't know whether if you're familiar with vascular, if you're medical professionals, you must have seen at least as medical students. So we deal with blood vessels in the body. Apart from the heart and the brain, all the other blood vessel problems are dealt by vascular surgery. So one of the common operations we do is problems with the main artery, which is called the aorta. So sometimes the aorta can balloon up. We can see like here on a CT scan, the aorta has ballooned up, and we go and repair this aorta either doing an open operation, which is a big operation, or we do a keyhole surgery, like shown here, by putting a stent. So I do both these techniques. Then again, we do a lot of lower limb work. So this is the most commonest operation we have on our repertoire. So we do quite a lot of surgery on the lower limb. So this is where I was showing like vascular. So this is an aortic surgery. This is the main artery in the body, and sometimes you get an aneurysm like here, and then we can do an open surgical repair, or we can even do an endovascular repair. And then right. So this is lower limb work. So we end up doing bypass surgeries for lower limb. So we can take your own vein, and then if there's a blockage, we can make multiple cuts and then do a bypass surgery, or we can do endovascular techniques where we don't have to make big cuts. We just go through your blood vessels, and we can put in stents, we can put in balloons, Or so that is like minimally invasive surgery. So I do both of these. Then again, talking about informatics, I so I got involved with multiple societies. Like I've been a British Computer Society member for a while. I have been quite active member of Open EHR, like from medical student days onwards. And then, of course, I'm involved with the NHS Python community, NHS AI virtual hub. Then, of course, Mark got me interested in FCI, and I became FCI member. And then I finally now working with after the BCS to co FCI. Now I've kind of moved to BCS, and we are organizing conferences, and um, we are also I'm doing a webinar series on digital health. So these are some of the projects I've been involved in. So as I said, I created this platform where you can. It's an online tool where you can put in operation notes, and you can look at entities or recognize entities in operation notes. So essentially, we were looking at things like what consumables did you use, what instruments did you use, what sutures, what graphs, and based on that NLP experience, then I created a OpNote annotator where you can create operation notes, and you can drag and drop things. Like, for example, if you use different kind of graphs, you can drag and drop it from a drop-down list. And then finally, you create your operation note, and you can cut and paste onto your EPR from that. So this is the kind of work. And then, of course, I have done like some database work. Again, I don't know whether you can see this. Let me stop sharing and reshare this. Because my training involved quite a lot of database work, so I can use SQL Server, MySQL, and lots of other database technologies. So, and I'm quite use SQL query languaging to do a lot of like searches. So I did. So this was the bottom one was a lower limb revascularization database, which I created for one of the big London hospitals when I was a trainee. And this, I think they used it for quite a long time, and I had to analyze the entire kind of infrastructure or the information pathways involved, and then I've created this where you could record all the revascularization procedures, both open and endovascular. And then I did something similar for Birmingham University Trust, where we collected quite a lot of data for research projects, again in aortic surgery. So I've done quite a lot of similar projects, and so these are all projects which I have done. And let me show you something which I've involved now. So essentially, this is something we just finished and about to launch. This is what we call a MedEd Connect. It's a medical education platform. The idea for this actually came from a medical student and a junior doctor. And basically, they were saying like, "Whoa, we are using apps for everything. Why can't we have an app where we can post medical education opportunities? Like, say, if I'm doing an operation, say I'm doing an aortic aneurysm surgery, and if there is a student of junior doctor who is interested in coming and seeing this procedure and learning from it, at the moment there is no place for them to look at and figure out where these operations are happening. So we created this platform with a group of another group of app developers, and for this project there were 3 doctors involved, including myself. And at the moment, you can go to this website, mededconnect.com, and register an account. We are about to go live in August with the new cohort of trainees who are joining Bart's Health. So hopefully, we've been testing with this platform for the last 2 months, and we've kind of ironed out all the bugs we have seen so far. But of course, I'm sure we'll find more. So essentially, this is going to be hopefully a pan-London project by next year, once it's implemented fully at St. Bart's. And then let me show you the next project I'm involved in. So this is, we call this renal flow. So my fellowship was in renal transplant and vascular access. And our hospital do quite a lot of vascular access procedures. That means you connect the artery and a vein, and that way you create a fairly big vein that has very high blood flow, so that you can connect these patients to a dialysis machine. These are mainly for patients who have renal failure, and they need at least 2 to 3 times dialysis. That means you clean their blood. The function that is normally done by the kidney is done by a machine, and for that you need to connect these patients, and the blood flow in the vein has to be very high, at least 600 mils per minute. So that's why we need to create a communication between artery and a vein. What we realized was that if at the moment the hospital pathways, or because we use quite old-fashioned software, we realized that there are quite a lot of inefficiencies the way we use health informatics in the NHS. So we thought, to overcome all these drawbacks, which we can discuss later, we created this renal flow, which is essentially a patient flow pathway software. It's actually, I think this is quite close to Mark. But Mark has done quite a lot of work on this area. I think advancing from Mark's work, this is trying to change the current paradigm of what we have as electronic health records, moving from that to electronic patient pathways, or EPPs. And we are in the process of developing this this pathway software with another private informatics company. Hopefully we should be able to get something out by next year. Then again, we're involved in several other projects, like where we are trying to look at how we can use computer vision in diabetic foot sepsis. Again, how to use AI in patient triaging. And also we are trying to see if we can create an outpatient booking system that is more efficient than the current existing systems. So these are some of the projects I'm currently involved, apart from my day-to-day work as a vascular surgeon. So I hope you all have any more questions, or if Mark has any questions, I'm happy to answer. I think that's all I need to present. I have prepared to present today.
Thank you very much, Sobath.
Yeah, sorry about the technical glitches, but I think it's maybe because of the NHS restrictions.
Yeah, no worries. I'm just going to put you on mute when I talk because a bit of feedback. But anyway, thank you so much for that. I think it's quite evident that in the NHS we have tech that can be a bit dodgy. We can talk about AI and large language models and all sorts of things like that, and still we have to sort of fight the technology that we have in front of us to do our everyday things. And doing this webinar now, it's quite evident that there was problems as well around that. No, thank you very much for that oversight, what you're doing clinically and actually digitally. It's really interesting to see the things that you're doing. There's one project, I think 2 projects there I didn't actually know you about that you were doing as well, the sort of the renal flow and so on. I just wondering if I could get sort of more of a sort of overview of how your background in software engineering has influenced your approach to sort of clinical practice and healthcare innovation, because it seems like you're doing quite a lot of it, but I just wanted to see how you feel that's sort of helped you sort of tackle these things and take them on and innovate and so on.
Thanks, Mark, for that question. So I have done quite a bit of training on requirements analysis, and that has made it quite helpful for me to look at these problems. Like, for example, when we were looking at the renal flow software, why we came up with that solution, because current system involves static electronic software where you have databases, and then you have schedulers, where and then of course you have the clinicians and the allied healthcare staff like the nurses and dialysis nurses and healthcare practitioners. So we have a disjointed system where we are all trying to do different things. Whereas if you, for a patient, it's just like a smooth pathway. So when I looked at it, like by looking at what are the requirements for a smooth, so a quick, end of the day, what we need is a fistula created quickly so that the dialysis can be done fairly quickly. Because if you delay, you end up putting in lines which ultimately get infected, they damage the blood vessels. So we're trying to prevent that. So when you look at the requirements, we realize that there are certain stages in creating a fistula. And if you map those stages into a pathway, then your electronic health solution becomes much more efficient. So that's where I came from, and we created that. And having that requirements analysis training was quite helpful. And then, of course, I've done some programming techniques and, of course, done some software development. And then it's easy for me to sit down with the developers, because actually I don't have time to write code now, especially for such a big project. So, but it's easy to engage with the developers, and I can tell them, look, why not we use this technology and not that technology? For example, in the MedEd Connect project, initially we were trying to use, I think the developers are trying to use relational databases. And what we realized was the response time is quite slow. And as we all know, most of the apps are using non-relational databases. So I could kind of convince them to move from relational to non-relational for that project. For that project didn't have that much data. It was very small set of data that we were using. So having this knowledge in software development, software engineering, and requirements analysis is quite helpful when you're creating these applications, because I can bring in my IT knowledge as well as the clinical knowledge, and you can put them together. That way, it becomes easier to develop these products.
No, thank you for that. And in some ways, I do envision you as the true embodiment of a clinician who codes, someone that actually has had the training in computer sciences and has also got a medical, surgical sort of training as well. And you know, the things you've been talking about, the fistulas and the safety aspects, of course, it's lovely to get digital to help us make those things happen better. We got a question from Robert Willems, who says, can Sobath see a future where NLP, so natural language processing approaches, can accurately convert free text notes to OPCS or SNOMED codes?
Yeah, it's a very interesting question. I thought somebody might ask something on this line. So because I was involved with OpenEHR, I kind of understood the importance of semantic mapping. Because I mean, before we had NLP technology, having a unified accepted data set was quite useful. But then when you look at the current advancement in NLP, I'm trying to think that these coding systems like OPCS or NLP, SNOMED, or even FIRE OpenEHR technologies might be a bit redundant in future. Because, say, for example, if you're being paid by OPCS codes, or you could easily create an NLP tool that can recognize this and because, say, for example, if you look at 5 different surgeons, they will write their operation notes in 5 different ways. This is what we have seen by doing some research on how clinicians write their operation notes, surgeons. But if you have enough resources, you can train a large language model, or even a non-large language model, like the model which I created was not a large language model. It's just like a neural network that kind of learn on the inputs you provide. And you can do, if you have the resources, you can do that. So in fact, we are trying to do a similar project with QMUL, our Queen Mary University of London, and our Bart's Health. We have a secure data environment where we have an environment which connects the university to the hospital. and we can explore different technical tools in this environment. Because one of the biggest problems is we can't deal with live data which is already in the electronic patient records, because if we do any damage or if we cause a security vulnerability, that will affect the entire hospital. So what they've done is they've created a copy of the data that goes to the secure data environment, and we can manipulate that environment in a secure way, so that we can try out these tools. So one of the things we are planning to do is to use NLP in patient discharge letters. Like, as you know, all hospitals have an army of coders who sit down and code just to get the reimbursement from NHS England. And the whole idea of this project is to try and see if we can replace some of the inefficiencies in manual coding.
No, thank you for that. I remember you talking to me about I think it's a sort of an academic practice that you were doing, where you're using large language models to actually read patient leaflets and pathway stuff, and then actually you can ask it a question about how do you get to this theatre, or how do you manage this thing, and so on. I don't know if you wanted to sort of talk about this here at all. Is that something that you're happy to talk about? Because it sounded very interesting.
Yes, Mark, thanks. So this is one of the ongoing projects. So we are trying to create outpatient booking system that also has an AI element to it, so that when the patient attend outpatient appointments, say for example, if it's coming to a venous clinic, we are trying to see as after they finish the clinic, when they go back, whether we could provide them with an NLP bot that can communicate with the patient. Because unfortunately in NHS we have very limited time when we see a patient in the outpatient setting. We have 10 minutes, sometimes 15 minutes. But the patients have a lot of questions, and some of the questions they get the questions after the clinical consultation. But then if they want to ask the question, they have to wait until you see them again, like maybe another couple of, maybe 6 weeks or a couple of months. But if you can provide them with a bot that can answer all the simple questions, and that way the clinicians can focus on more complex scenarios or complex questions. So this is one of the projects I'm involved in. We hope we can use the transformers in large language models, but we're not going to use the knowledge base behind the large language model, because that is where all the inaccuracies happen. We are using the transformers. That means the knowledge comprehension component of it, and then we will put in our own information, and the bot will interact with our information and then provide that to the patient based on the questions they ask.
Yes, thank you so much for that. It's quite evident from what you're doing, and I think with the mededconnect.com app, if I may call it that, that you're doing, I understand the sort of underlying stack, but I'm not going to go through that now because we've spoken about it at length before. But it's quite evident from what you're doing, your understanding as a clinician, surgeon, and also computer scientist with, expertise around analysis and user-centered design and so on. I'm just wondering, slightly tangent question, but I was just wondering, what strategy do you recommend for effective training and supporting clinicians in adopting new healthcare technologies? Because myself, I don't see a huge amount of good training out there, and I think at a national level we should even have that. And you and me have spoken about this as something that that should be doing through other entities, for example, the British Computer Society. But I'd like to get your opinion on how can we scale out, train better, get everyone up to the right level of digital literacy, if you want to call it that, and actually help improve our understanding and usage and building even of digital systems to help clinicians.
Yeah, thank you, Mark, for that question. I think this is quite important because we are seeing an explosion of technology in the healthcare domain. But unfortunately, we haven't paid enough attention to this in our undergraduate curriculum. I know that, Mark, you have been involved in trying to get GMC interested in recognizing digital health as a specialty when you're in the FCI. I think it should start at the medical school level, because a lot of people, I mean, I didn't know until quite late that what are the coding systems involved. It's because I was interested in digital health, I kind of learned it on my own. But I can remember medical schools have never taught this. And then this is one of the surveys we were planning to do through FCI before it got closed down, was to find out what kind of digital health teaching that is going on in our undergraduate curriculums. I think we are hoping to take that forward through BCS, and we're trying to figure out how many universities are actually teaching digital health as part of their curriculum. If not, how we can improve that education. I think it should start from medical school, but then go on through to surgical, like different levels of training. Now, I need to commend the Royal College of Physicians, because they have a stream where you can become a digital health clinician as part of your registrar training. What we need is something similar to that, especially for people who are interested. I think if we can have our own college, like a Royal College, that is where we can create our own kind of syllabus. I know, Mark, you have been working on a syllabus for like undergraduates or even postgraduates who want to learn about digital health. So this is quite important. And then finally leading on to accreditation, so that you can get yourself qualified as a digital health technologist, or you can call yourself a clinical informatician. Now, BCS is trying to use an Australian accreditation system, and they're planning to introduce it hopefully next year. But then we have to do our own work to create our own accreditation system within UK. Unfortunately, we don't have that, and this is one of the things I've been canvassing in FCI and as well as in BCS. I think we need this quite urgently, because a lot of doctors are now involved in digital health projects, but they need the correct training. They need to know about what things to learn, at least as a syllabus. And I think it's commendable, Mark, that you are doing some of this work on a freelance basis, but hopefully we can use your work at BCS.
No, thank you for that, Sobath. And I probably should do a big call out to everyone in the FCI that was involved with the professionalization work. There were so many people involved. Some fantastic work that happened there, but of course there's barriers in the way when you're trying to do any sort of national change, to have syllabuses changed, to add digital, to have training changed from undergraduate level upwards, and so on. But yeah, it was a team effort. We tried very hard, and of course the FCI unfortunately had its own internal battles and financial issues, so that unfortunately stopped there. But I would love, well, I am continuing it as much as I can in my free time through Let's Do Digital, but I want to engage myself with anyone that wants to make these things happen. I even wrote the syllabus, the curriculum for postgrad training as a speciality, just as sort of a pipe dream almost, but just to, see that, this is possible. We could write these sort of things. Just to take a different tack as well. Sorry, my daughter's just walked in. I wanted to sort of get your idea on the balance that you need for detailed data entry in EPR systems with the time constraints and workload pressures faced by clinicians.
This is a good question, because at the moment we are using a very old-fashioned way of entering data. So we either dictate our letters or we type them, and there are better ways to improve this, because if you're dictating, then the dictation gets typed by a different party, which takes some time. And then again, when you get the dictated letter back, there are quite a lot of errors, which means you have to correct those errors, and the whole process takes a long time. And by the time the patient gets the letters, or the GPs get the letter, it has taken quite a long time. And of course, we're using the technologies we have at the moment, like, for example, the Whisper data model by OpenAI. You can easily convert voice to text, and that can be incorporated into EPRs. Again, I've seen there are quite a few companies who have used this technology and trying to implement it in different medical domains. For example, in GP practice, I think some of the EPRs are trying to incorporate voice recognition. This is, I think, a step in the right direction because, but one of the problems here is even the Whisper model. When I've been experimenting with it, it hasn't. Some of the medical terms it can recognize, but there are quite a few that it can't recognize. And again, this is where I think it's important to have a model that can understand medical terminology. So I think if one of the big companies like Google or Microsoft can work on that, or even OpenAI can work on that, it's an ideal opportunity to create a speech to text language model for the medical domain, especially in incorporating our medical terminology, especially in different specialties. Like, for example, in my specialty, when I say claudication, the Whisper model can't understand that, and it tries to guess and gives the best guess word next to it. But I think there's a big opportunity there. We could do something.
Thank you for that, and sorry about the my daughter coming in. The movie that Butron had just finished, but my next question following on from that is, in your experience, what are the key factors that influence a clinician's acceptance and usage of a new digital tool and system? I'm very curious to get your take on it, someone that really understands the digital, understands what's possible from a front end, back end perspective, but also as a clinician who has to use these sort of entities every day.
Yeah, Mark, I have seen this day in, day out in clinical practice. When you try to implement a new system, there's quite a lot of friction because it's, again, people, especially when you're doing a busy job, you get used to doing work in a particular way. And then when you try to change, there's always resistance to change. And it's kind of part of human behavior. And I think it's taught as part of software implementation strategies that there are different things you can do to implement this in a stage fashion. But unfortunately, in the NHS, what I have seen is when we are introducing most of these new technologies, we don't use the theoretical knowledge. We basically implement them in a brute force fashion, and which can give us a lot of problems, and there's a lot of resistance. Again, one of the problems might be lack of funding, because you need to do a lot of training, and we haven't. One is we can't free clinicians to go and do a day of training, because that means you can't do clinics, you can't do theater lists on that day. And again, the money involved, because you to develop training modules, training environments, again, cost a lot of money. So I think maybe this is one of the main reasons. But if you do it in a properly staged approach, where you train the clinicians properly and show them the advantage of the new system, I'm sure there will be people will definitely buy into it. And again, I think even though it's more expensive, I think we should pay more attention to these training exercises, because that can reduce quite a lot of errors. And also, again, patient safety, because there are patient safety incidents that happen every time you introduce a new clinical system. And you can avoid all these if you do the proper training and proper implementation.
Thank you for that. Yes, no, definitely all of that and above, and then some. And a question leading on from that Jeff Tanner just brought up, very interesting to get your take on this, because something that my wife, who's an oncology consultant, is thinking of incorporating is these medical speech to text platforms, and actually these ones that listen to your consultation with the patient and write your clinic letter from that. It can understand both sides of the consultation, not just directly transcribing what you say, but actually summarizing as well. But the issue that Jeff brings up, and a concern of myself, and actually I've had with other colleagues as well, is sort of, are these, AI driven, whether it's AI or not, but are these systems which may keep all the data and all the vocal recordings local or actually sent us to the cloud somewhere, whoever knows where, are they confidential enough? And, what's your take on that? Should we be using them? Do we need to make sure they're much more secure than they are, and so on?
I think this is a kind of a minefield, because this is one of the biggest problems in using AI or NLP or any machine learning technology in day-to-day practice. So you need to look into each stage of the pipeline when you start entering data to getting the output from the other end. Yes, they could easily capture what you are saying, and you can store it, and they could use it to train their own models and improve them. And there is a patient safety concern there. But then again, you have sometimes you have to let these things happen as well, because if, say, for example, you have a proprietary language model and you want to improve it, the best way you can improve it is by testing and training and the model. And for that, you might have to keep some of that data. But if they do it in a transparent fashion, and if they destroy that confidential information later on, that still, I think, in my book, is okay, as long as you don't use the personal information, but you just improve your model. That will help the model to improve over time. But again, I think you need to look into the entire pipeline when you how the data is used within the software. And I think this is going to be a big problem in future, unless we have clinicians or informaticians who can look into all these aspects in the new tools that are going to be introduced in the NHS or any healthcare domain. We won't be able to see all these nuances.
Thank you very much for that. I'm going to end on another tangent, slight tangent, but sort of leading on from what you've been talking about today and some of my own wishes and wants. You're building what sound like fantastic apps, useful apps, apps that can make our lives, patient lives, admin staff lives better and safer. But we need them to connect. We need interoperability to get these systems to work properly. And you've mentioned FHIR, and we've had SNOMED terminology and stuff like that. But sort of to try and end on a sort of positive note, hopefully, how do you envision the future of healthcare data interoperability, and what steps should be taken to achieve seamless integration across different systems and platforms?
Yeah, I think, unfortunately, I think still we are looking at the health data from the technical advances that happened almost 2 decades ago, maybe more than a decade ago. So we're still using things like the semantic mapping in an era where we have text to speech and natural language processing. So what I think the future would look like is, maybe we will create language models that can automatically understand or have comprehension of medical terminology. And I have a feeling that some of these models, or some of these semantic models, for example, like SNOMED, might be redundant in future. But of course, you need to train these models, and finally you need to agree on a final terminology data set. So that data set might still be there, but I have a feeling that interoperability will be much easier in future, because if the machine can understand what the clinician is trying to say and record it, and when you play it back, or when you look at it, if another clinician can understand, that means there is interoperability, as well as if a non-clinician can also understand. For example, sometimes the patients need to understand before they give consent. So if these constraints or requirements are met using any technology, could be NLP, could be any other model, then interoperability much easier. But again, I think the requirements of a strict semantic mapping might not be required. I think it was required before, maybe 10-20 years ago, when you didn't have the NLP technology, but now I think it's becoming less useful.
Thank you very much, Sobath, for all of that. And thank you for taking the time to talk to us, everyone that's online. We had some very interesting questions. I had a few of my own that I threw in there. I hope you don't mind. And yes, that's Sobath from Bart, software engineer, I think, at Heart Steel, very much practicing, and also a vascular surgeon. So in my mind, the embodiment of a clinician who codes. I just wanted to share what we'll be doing next week. We have another Asking a Clinician webinar as well with Ramandeep Kaur, who is a pharmacist and Chief CCIO at the University Hospital of Northampton. We've also got Alex Chung, who's working for LSX, one of the senior managers at NHS England, talking. But yes, fantastic to have you on board, Sobath. Thank you so much for answering our questions and giving us your time talking about both worlds and how they interact, digital and surgical. And thank you so much for everyone who else has joined us. Bye for now.
Thank you very much, Mark. Thanks for having me.